Thank you all for taking your seats for the final session of the workshop. This is session 6, Stakeholder Perspectives, Goals of the New Paradigm and Priorities for the Path Forward. And I think many of you were present when Dr. Shilsky announced that this was going to clarify the vision that we've all developed over the last day and a half. I want to thank in advance our panelists. This will be essentially a pure panel discussion. We have Howard Burris, who's CMO at the Sarah Cannon Research Institute. Dr. Jaffe had to leave us to attend the ceremony at the White House, so she won't be here. Dr. Lynn Matresian, who's the Chief Research Officer at the Pancreatic Cancer Action Network. Dr. Eric Rubin, VP of Oncology Clinical Research at Merck. Amy McKee from the Food and Drug Administration. She's acting Deputy Director in the Office of Hematology Oncology Products. Jeffrey Brown from Harvard Pilgrim Healthcare Institute and the Department of Population Medicine at Harvard Medical School. Rebecca Pence, Emory School of Medicine, a Professor of Research Ethics, and Ronald Klein from CMS, where he is Medical Officer. So that's our panelists. I'm going to invite each of them to, if they wish, to give a 5-minute introductory remark or remarks with slides if they'd like. If you prefer not to make introductory remarks, that's fine also. So maybe we'll start at this end with Howard.
Thank you very much. I appreciate the intro, and I'll spare the slides. I enjoyed the conversation. And at Sarah Cannon in Nashville, not a single institution, but in fact an institute that focuses on advancing drug development and studying cancer agents across our many sites throughout the United States. So we work primarily with large community practices, some of the bigger ones in the country, practices such as Florida Cancer Specialists and Tennessee Oncology that see tens of thousands of new patients a year. So my first comment is about the community. I think, the community takes on a number of different thoughts when you think about how to bring that into the world of cancer. About 85% of patients, give or take, are seen in what we would consider the community, which would be not being seen at a primary academic institution. That being said, the irony of that always is that all the oncologists in our network were trained at all those same academic institutions. So they're coming from Dana-Farber, University of Chicago, Johns Hopkins, and the like, and are very good medical oncologists, as well as the surgical oncology talent also comes from the same institution, so that's great. And the community isn't Nowheresville or Bug Tussle. The community is interesting. Our largest community sites are places like Nashville, Tennessee, Kansas City, Missouri, Denver, Colorado, Sarasota, Florida, Richmond, Virginia. So, fairly big cities that might not always have a prominent institution that might serve a very niche, but in fact, these are large metropolitan areas trying to get drugs out to the community in the framework of getting it to where it's a reasonable position for a patient to travel, knowing that in fact flying to New York or Chicago or Houston isn't practical for most patients that are out there. We also believe that that's probably one of the keys to accelerating drug development. First off, it gets you out to, I would think, a more routine or standard or typical group of cancer patients, and then secondly, you certainly have increased the pool of patients by taking the trials as practical out to those types of communities. Now, the infrastructure investment's huge. I mean, we spend several $1 million to put in what we would consider a drug development unit or phase 1 program there and staff it up appropriately. I mean, it isn't something to be taken lightly. The ability to have 14-hour clinic days and adequately staffed with nurses. I always joke that drug development's about having a good doctor and great nurses, because the data comes from the great nurses doing their job appropriately, as well as the various laboratory technicians. So our commitment's strong in that direction. So again, I think one theme I'd just like to mention is trying to get these therapies and the trials closer to home within reason. Second thing is just the absolute fear around molecular profiling. And that's been published from large academic institutions. I think the fear is different in the community. I think private practice medical oncologists who are busy hate to order a test that they don't know when they're getting the result back and that they might not understand the result. It's common, we joke that in practice, you get your radiology and pathology report back and it's 3 pages long, but you read the 3 lines that are the assessment and conclusion, which is really what you want when you're busily seeing patients during the day. There's been strides on the profiling front, but I think we've got to get in drug development past this paradigm where we're looking for the light switch. So, we got spoiled with CML, where you had the mutation and you had the drug, and now we've got other examples of that. We were talking about ALK inhibition. Now there's a lot of patients that are now getting on trials around getting an ALK inhibitor for lung cancer, and you can take that analogy to various diseases. And I think we're trying to get to a place, and I've talked to Dr. Shilsky about this over the last year or so, that how to bring an analysis and some sort of software into the EMR where you can take this profiling data and make it usable for doctors and not necessarily make it one mutation, one drug, but the spectrum of what you find in that profiling report, deciding how you should best treat that patient. There's data that comes back that simply suggests a patient should get a platinum-based regimen or not, should get some conventional therapies, might or might not benefit more likely from an immunotherapy, and on and on. So I think we're looking also at making the investments to try to pool that together and you make that a bit of data for our physicians and for the patients as well. And then lastly, the other place we've made a substantial investment has been in nurse navigation. That affects a variety of patients, but trying to capture that patient, not step in front of the physician, but facilitate the physician right at that point where the patient gets that scary, you got a mass, you need a biopsy, or you have a cancer diagnosis, and take them by the hand and take them through the treatment paradigm. I'll give you some quick statistics. By having a nurse navigator, we've more than doubled the number of patients in the community that are now discussed at a multidisciplinary conference, which is a huge step forward. And the data rolling from that is about 1/3 of the time the treatment decisions are changed. A second thing is we've shortened the time to get from diagnosis to first treatment by 20–25%, but even more important than the time shortening is the patient seeing the various specialists so they get an informed opinion prior to initiating that very first treatment. Kind of goes hand in hand with the multidisciplinary conference. And then lastly, much harder to measure, it's that satisfied patient, satisfied physician experience. Really, really hard to measure. And my final comment, I was joking when we did the first surveys, when a woman goes through her initial breast cancer treatment or a man's gone through their initial prostate cancer patient, it isn't like they're filling out a card where the food's better since the last time I ate here, or the accommodations are better than the last time I stayed in their hotel. Their point of reference is that one time for that one experience, which needs to be as great as it can be. And that's hard. That's hard to measure. But I think that the investment for nurse navigation has certainly, subjectively to date, been an improvement for the patients.